Good afternoon, dear colleagues. Today lecture is devoted on the topic inflammation. Inflammation is complex stromal vascular response to injury aimed to eliminate the injurious agent and to restore the damaged tissue. There are few aims of inflammation. First purpose: delimitation of area of damage. Second, destruction of agents that cause inflammation. And third, restoration of damaged tissue, repair. First of all, during evolution, inflammation was developed like adaptive and protective reaction. But there are some negative effects caused by inflammation. The inflammation can be accompanied by separation of the tissue with the formation of fistula and massive scarring, and inflammation is basis of many diseases and even can cause death. To form the name of inflammation of particular organ, we need to use suffix "itis", adding to the Latin or Greek name of the organ. For example, for liver, in Latin is named hepar. Hepatitis, it is name of inflammation of the liver. Gastritis, the oral cavity is named stomatitis. Appendix, appendicitis, and so on. Inflammation can be classified by several parameters. First parameter about causative factor. Such factor can be of physical nature, chemical nature, and biological factors. The physical factors are radiation, electrical damage, high and low temperature, mechanical trauma, pressure, atmospheric pressure first of all. For chemical factors, there are acids and bases, drugs, toxins, poisons, even medicines in inadequate dosage. For biological factors, we need to mention bacteria, rickettsia, viruses, protozoa, immune factors like antibodies, immune complexes, sensitized lymphocytes, complement system, and so on. Second classification according etiology. Inflammation can be specific and non-specific. Specific inflammation is caused by certain factors that has characteristic morphological features. For example, Mycobacterium tuberculosis, bacteria which cause tuberculosis, have specific morphological picture with development of typical granulomas, about which we will discuss later. Leprosy, syphilis, and so on. In non-specific inflammation, the process can be caused by different factors and, non-depending on the reason, have the same clinical and morphological picture. Of course, we need to mention that such specificity is not absolute, because even in specific microorganisms and diseases like tuberculosis, syphilis, and so on, there are some features which are similar one to another. Next type of classification according duration of inflammation. It can be acute, when inflammatory response is developing during days or few weeks. It's characterized by predominance of exudative tissue reaction and rapid completion of the process. Usual duration for acute inflammation is from few days till 6 weeks. Subacute inflammation, it is inflammation duration of which is lasting from 6 weeks to 6 months. Chronic inflammation long process, half a year and more, when the tissue damage and reactive changes and process of healing occur simultaneously. Periods of exacerbation when the picture, clinical signs and morphological signs will resemble the acute inflammation will be replaced by periods of remission with particular healing and scarring of the damaged organs and tissues. Next classification is about type of tissue reaction. According to this classification, inflammation can be divided into norm-ergic inflammation, hypoergic inflammation, and hyperergic inflammation. Norm-ergic inflammation is adequate variant of response of organism to damaging factors. The outcome is usually favorable. It is healing and complete restoration of function and structure of organs and tissues, with total elimination of damaging factors. Hypoergic inflammation is inappropriately weak response to the harmful effects of damaging factor. Inflammatory response may be due to depletion of the protective forces of the organism caused by previous disease, physical stress, starvation, weak type or high nervous activity, and so on. Due to defective insufficient inflammatory response, the organism cannot eliminate and stop the damage caused by factor, and that's why hypoergic inflammation very often is accompanied with spreading of process to adjacent tissues and even to generalized type of infection, which is named sepsis. Hyperergic inflammation occurs in case of violation of adaptive and trophic functions of the nervous system, in allergic conditions, in autoimmune diseases, and some infectious variants of inflammation. Is characterized by very severe and not adequately harmful damage. Necrotic process predominate over regenerative process. Hyperergic inflammation, it is base for autoimmune disorders. Proliferative inflammation can be classified according to the stage which predominate. There are three typical stages of inflammation: alteration, exudation, and proliferation. According to this classification, due to predominant stage, inflammation can be exudative or proliferative. About alterative inflammation, few words I will tell later. In ancient period, the antique doctors classified 5 typical signs of inflammation. First sign, it is rise of the temperature, fever, heat. In Latin, it is named calor. Second, it is redness of the inflammatory focus due to hyperemia. The Latin name, rubor. Third sign, it is swelling of the inflammatory focus, edema. Latin name is tumor. Fourth, pain due to the damage of the nerve endings. Latin name is dolor. And the fifth last feature of inflammation, it is loss of function of inflamed organ. In Latin, functio lesa. In morphogenesis, there are 3 stages of inflammation, and first stage of inflammation is named alteration. Alteration, it is damage of the tissue. It defines an initial phase of inflammation, manifested by various types of dystrophies and of parenchyma and stroma of organs, up to necrotic changes. Initial phase of inflammation leads to the release of mediators that determine the subsequent development of inflammatory response. There are 2 types of alteration. It can be primary alteration and secondary alteration. Primary alteration is caused by direct damage of the harmful factor, and it prolongs its pathogenetic effect. The extent and nature of the alteration depends on the intensity and quality of the pathogenic factor, location of the damaged area, as well as resistance of the damaged structures to the whole body. Secondary alteration is caused by influence of various pathogenic factors, both like local factors, physical and chemical factors, amount and activity, inflammation mediators, vascular reactions, and so on, and also systemic factors such as nervous, humoral system, influences of immune system, and so on. Secondary alteration is usually caused by mediators, by inflammatory cells, and so on. The second stage of inflammation is named exudation. It is a reaction of the microvasculature with changes of the rheological properties of blood, symptoms of increased vascular permeability, phagocytosis, and formation of exudate. The following processes are the basis of exudation. First of all, reaction of the microvasculature with impaired blood rheology. Second, increased vascular permeability at the microvasculature bed. Third, exudation of blood plasma components. Fourth, emigration of blood cells. Fifth, phagocytosis, engulfment of damaging agent. And sixth, formation of exudate and inflammatory cell infiltration. Exudate, it is muddy fluid enriched by proteins, more than 2%, and hematogenous cells, and inflammatory nature histogens, which exist from small blood vessels and accumulate in the site of inflammation. A cluster of cells in tissue is named inflammatory cellular infiltrate. Exudate usually contains inflammatory cells and accumulates in the cavities, like cavity of the bronchus, pleural cavity, lumen of GIT, and so on. When we are speaking about inflammatory infiltrate, it is usually accumulation of cells not in the cavity but in the tissues. For example, accumulation of cells in the interalveolar septa, accumulation of the cells in the wall of bronchus, in the wall of organs of GIT, in the liver, parenchyma, and so on. The composition of exudate is slightly different depending on time after start of inflammation. During first 6-24 hours, exudate consists predominantly from polymorphonuclear leukocytes, from the neutrophils. Between 24 and 48 hours, predominant cell types are monocytes and macrophages. When inflammation is associated with immediate hypersensitivity reaction, or it is associated with parasites, the predominant cell type in exudate are eosinophils. Last, third stage of inflammation is named proliferation. It provides reparative tissue regeneration at the site of damage. Proliferation is characterized by proliferation of inflammatory cells, such as macrophages, also proliferation of cambial mesenchymal cells, smooth muscle cells, epithelium, and so on. Secondly, it is differentiation and cell transformation. For example, monocytes transform to macrophages, and they are transformed to the epithelioid and giant multinucleated cells. B lymphocytes can be transformed into plasma cells, which produce antibodies, immunoglobulins. Cambial mesenchymal cell can be transformed into the fibroblasts. Cell proliferation in the area of inflammation, with appearance of a lot of fibroblasts, used to repair damaged tissue or delimitate the inflammatory focus. As we told before, there are three main type of inflammation according predominant stage: ulcerative, exudative, and proliferative. First of all, few words about ulcerative inflammation. Nowadays, there is no such variant of inflammation as ulcerative. Until recently, among the morphological types of inflammation, ulcerative inflammation was present and was characterized by prevalence of necrotic inflammation, necrotic process. But exudation and proliferation phases are presented very poorly or not at all defined. That's why nowadays pathologists consider that there is no inflammation when only dystrophy and necrosis present without subsequent reaction of microvasculature bed, because the exudation and proliferation is the main phases in inflammation. If there is only necrotic damage, we can tell that this is necrosis but not inflammation. Examples of ulcerative inflammation which were counted before, when it was not excluded from the inflammation types, they were ulcerative myocarditis and polyneuritis in diphtheria, viral encephalitis, poliomyelitis, or, like in this photo, acute viral hepatitis A. As I told before, nowadays there is no such term as ulcerative inflammation, and it has only historical significance. Exudative inflammation is characterized by predominance of exudation and formation of cavities in the tissues with the presence of exudate, or exudate can accumulate in pre-existing cavity. According to nature of inflammatory exudate, there are few types of exudative inflammation, which are serous inflammation, fibrinous inflammation, purulent inflammation, putrefactive or putrid inflammation, hemorrhagic inflammation, catarrhal inflammation, and mixed inflammation. First of all, we need to know the difference between non-inflammatory fluid, which can accumulate in cavities, which is transudate, and inflammatory fluid, which is exudate. Transudate is plasma of the blood without changes in vascular permeability. Exudate, it is plasma of the blood without changes in vascular permeability also, but it is corresponded with the edema of inflamed tissue associated with increased vascular permeability. Transudate, it is non-inflammatory fluid, but exudate is inflammatory fluid. In transudate, there is low protein content, less than 2% protein. Mainly this is albumin with no propensity to thicken. In exudate, there is high protein content, more than 2%. Easily condenses due to the high content of fibrinogen, which can transform to fibrin, and other coagulation factors. In transudate, there is small number of cells, and predominantly these are mesothelial cells and cell detritus. There is no inflammatory cells usually in transudate. In exudate, there is large number of cells, and inflammatory cells predominate. Examples of transudate is edematous fluid in congestive heart failure. For example, accumulation of edematous fluid in abdominal cavity is named ascites. In pleural cavity, hydrothorax. In pericardial cavity, hydropericardium. Generalized edema of the body is named anasarca. These are all processes accompanied with accumulation of transudate. Exudate, for example, it can be purulent exudate, pus, fibrinous exudate, serous exudate, and so on. Serous inflammation. It's type of inflammation in which serous exudate will be accumulated. It usually contains not large amount of protein, more than 2%, but not such high content of protein like in other types of inflammation. Usually passes like acute process. Etiology, these are thermal and chemical factors viruses, for example herpes viruses, some bacteria and rickettsia, allergens of plant and animal origin, autointoxication, and others. Most often it is located in serous or mucous membranes, skin, or sometimes in internal organ, in the liver between sinusoids in perisinusoidal space, in the heart between muscle fibers, in the lumen of glomerular capsule in the kidney, accumulating in stroma too. Morphologically, serous exudate is slightly hazy opalescent yellowish fluid. It contains mainly albumins, globulins, lymphocytes, very small amount of neutrophils, epithelial and mesothelial cells, and partially resemble in its appearance transudate. But compared to transudate, it is inflammatory fluid. Outcome is usually favorable. Even significant amount of fluid can be dissoluted. In the internal organs, one of the outcomes of the serous inflammation can be chronic course resulting to sclerosis, but it's very rare outcome. For example, on the photo we can see the skin, keratin layer, multilayered squamous epithelium which is epidermis, and dermis with blood vessels. Between epidermis and dermis there is cavity, the bulla, filled with serous exudate, and we can see the composition of this serous exudate. First of all, it's fluid rich with some particular proteins. They have eosinophilic appearance, pinkish in color, and some inflammatory cells and cells from the damaged tissue. In inflammatory exudate, lymphocytes are usually predominate over the other inflammatory cells. Next type of inflammation is named fibrinous inflammation. Fibrinous exudate contains large amount of fibrin, which is formed from fibrinogen by the action of tissue thromboplastin. Usually fibrinous inflammation is caused by diphtheria and dysentery, Frankel diplococci, streptococci, staphylococci, sometimes Mycobacterium tuberculosis, influenza viruses, endotoxins like uremia endotoxins, and exotoxins, for example mercuric chloride. Usually fibrinous inflammation localized in the mucous and serous membranes forming films, which are typical and specific for this type of inflammation. Sometimes it can develop in depths of the organ, like Crupus pneumonia in lung. Depending on the nature of the fibrinous films and underlying tissues, there are two types of fibrinous inflammation. They are Crupus inflammation and diphtheric inflammation. Crupus inflammation developed primarily on serous and mucous membranes covered with cylindrical epithelium. The forming films are loosely adherent to underlying tissues. There is shallow superficial necrosis and fibrin deposits in the necrotic masses. Fibrinous thin film containing fibrin with some neutrophils can be easily detached. On the place of detached superficial fibrin film, superficial defect of the tissue can be found. Such superficial defects are named erosions. Examples of Crupus inflammation are, first of all, it is fibrinous pericarditis, inflammation of the pericardium of the heart, which has typical macroscopical appearance as shaggy heart. Fibrin threads accumulate on the surface of pericardium and give the heart hairy appearance, Latin name cor villosum. Microscopically, we can see the wall of the heart, myocardium, and superficially large depositions of fibrin with some basophilic nuclei of inflammatory cells, which are neutrophils. Because of inflammatory damage to pericardium, adhesions can be formed between layers of pericardium, with subsequent obliteration of the pericardial cavity. Sometimes sclerotic membranes of pericardium become calcified or ossified. The name of such complication is stone heart. Next example, it is crupus laryngitis, tracheitis or bronchitis, usually developing in diphtheria. Such severe condition is named true croup. Macroscopically, we can see whitish-grayish films on the surface of the mucous membrane of the larynx and trachea. Film is loosely adhered to underlying tissues and therefore can be easily detached. The mucous membrane is thickened and swollen. When detached, there is defect on the place of the rejected film, but this defect is superficial, as I told before, and this defect is named erosion. Microscopically, we can see superficial necrosis infiltrated by fibrin with small amount of neutrophils and single macrophages. True croup, it is complication of diphtheria in larynx, diphtheric laryngitis, when the films detaching easily from the inflamed mucous membrane of larynx and accumulates in the most narrowed part of bronchial tree, which is vocal cords. In false croup, there is also asphyxia, but the reason is different. In true croup, it is obliteration with detaching films, but in false croup, it is narrowing because of severe edema and accumulation of viscous mucus inside the lumen of the larynx. Both croup cause asphyxia, but the reason and pathogenesis is slightly different. Outcome of crupus laryngitis can be complete regeneration, can be complicated with unfavorable outcomes like true croup with massive and severe asphyxia, and sometimes the erosions which are formed on the place of detaching films can give small amount of blood with superficial bleeding. Next example of fibrinous inflammation, it is crupus pneumonia. Pneumonia, it is inflammation of the lung. It's a small exception from common rules of formation of the name of inflammation. We can wait that the name of inflammation of the lung will be pneumonitis, but pneumonia, it is historical term which was entrapped by the medical literature. In the left photo we can see inflamed lobe, which is grayish in color and has dense consistency. Because it slightly resembles the liver, the name of such stage is named gray hepatization, because lungs becomes similar to the liver in the macroscopical appearance. Microscopically, in the lumen of alveoli, we see multiple neutrophils with pinkish threads of fibrin, single alveolar macrophages, edema, and inflammatory hyperemia in the blood vessels. There are a lot of different outcomes and complications of the crupus pneumonia, including favorable outcome, which is a resolution of inflammatory fluid with complete regeneration, and unfavorable outcomes such as carnification of the lungs, abscess formation, pleurisy, and a lot of other different complications. Second variant of fibrinous inflammation is diphtheric inflammation. Usually it develops in the mucous membranes covered with stratified squamous epithelium, and films which are formed closely adhere to underlying tissues. Sometimes diphtheric inflammation can develop in tissues covered with columnar epithelium, but in these cases it is usually accompanied by deep necrosis. So two variants, or diphtheric inflammation developing in mucous membranes covered with stratified squamous epithelium, or diphtheric inflammation sometimes can develop in columnar epithelium, but in case of deep necrosis. For example, deep necrosis in dysentery colitis. It is inflammation of colon in infectious disease Shigella dysentery. We can see formation of 6 yellowish in color films which closely adhere to underlying tissues and can be removed with large effort. If this film will be removed, on the place of film we will see deep defect, ulcer, which is very often accompanied by such complications as hemorrhage and even perforation of the hollow organ. Microscopically we see large area of necrosis infiltrated by fibrin and multiple neutrophils with single macrophages. Hyperemia and edema of the tissue is present. Mucous membrane in the intestine totally absent because it is necrotized. As I told before, complications of diphtheric inflammation usually more severe than in lupus and including scarring, organization of exudate, severe bleeding and even perforation of the hollow organs. Next type of inflammation is purulent exudative inflammation. It is characterized by predominance of neutrophils in the exudate or infiltrate. Etiology: this is pyogenic bacteria like Staphylococci, Streptococci, Gonococci, Meningococci, Pseudomonas aeruginosa, Actinomyces, and so on. Main feature in morphology it is histolysis. It is destruction of the tissue with proteolytic enzymes of neutrophils. There are 2 main types of purulent inflammation, which are limited purulent inflammation and diffuse. Limited purulent inflammation includes such pathological processes like abscess, furuncle, and carbuncle. Abscess: focal purulent inflammation with the formation of cavity filled with pus. Abscess can be also subdivided in 2 subtypes, which are acute abscess and chronic abscess. Not only duration is different, but also the structure of the wall of abscess. On this photo we can see acute abscess in the lung. The cavity, which is filled with pus, and it is bordered from healthy tissues only with one single layer, which is granulation tissue, pyogenic membrane. Microscopically we see billions of neutrophils, necrotized tissue of the lung, dark purple colonies of bacteria, and pyogenic membrane with blood vessels, which is represented by granulation tissue. In chronic abscess, the difference will be presence of second layer outer from granulation tissue. Second layer is named fibrous connective tissue and it forms dense capsule around the focus of inflammation. So abscess, cavity filled with pus and formed due to action of proteolytic enzymes from neutrophils. Furuncle and carbuncle, both of them are necrotic and purulent damage to the skin. Furuncle, it is necrotic inflammation of hair follicle, sebaceous glands and surrounding connective tissue caused by pyogenic bacteria. The appearance of furuncle, it is reddish, elevating over the adjacent tissue area in the skin. Usually hair is present in the center, yellowish center due to accumulation of pus in the hair follicle. Later this pus was removed by himself, and on the place of furuncle we will see formation of thin, fine scar. In carbuncle, the severe inflammatory process affects few hair follicles and sebaceous glands. So usually carbuncle develops like fusion of few adjacent furuncles. It affects not only hair follicles and sebaceous glands, but also spread to the dermis, subcutaneous fat tissue, and sometimes even to the muscles. Very severe condition with severe intoxication. Diffuse purulent inflammation also has three subtypes, which are phlegmon, empyema, and cellulitis. Phlegmon, it is diffuse purulent inflammation without borders, most often occurs in subcutaneous tissue in the fascia along the neurovascular bundles. May also occur in parenchymal organs and meninges of the brain or spinal cord. Phlegmon is always acute inflammation. According to consistence, phlegmon can be dense and soft. Dense or hard phlegmon. It is variant of phlegmon with predominant coagulative necrosis. That's why the consistence of inflamed tissue will become dense. In soft phlegmon, the predominant process is liquefactive necrosis, lysis of the necrotic tissues. That's why soft phlegmon has flabby consistence. In the photo we can see phlegmon of the lower extremity. Cellulitis, it is inflammation of subcutaneous fat tissue. And cellulitis, it is the particular variant of phlegmon. Empyema, another variant of diffuse purulent inflammation. Empyema is defined like purulent inflammation with accumulation of pus in enclosed or poorly drained pre-existing cavities. That means that an empyema, pus is accumulated not in the new formed cavity, but in pre-existing cavity, like pleural cavity, peritoneal cavity, abdominal cavity. The cavity of gallbladder, cavity of urinary bladder, cavity of appendix, and so on. On the photo we can see empyema of pleura, accumulation of pus in the pleural cavity with damage to the pleura and accumulation of pus on the surface. Outcomes and complications of purulent inflammation are usually severe. Complete regeneration with formation of the same tissue which was before damage is impossible. That's why purulent inflammation usually accompanied by scarring. Scarring can be considered like partially favorable outcome. Sometimes it can be petrification of purulent foci. But in majority of cases, purulent inflammation can be unfavorable. Unfavorable outcome, it is spreading of pus to adjacent tissues, even with generalized infection, which is named sepsis. Long-term chronic purulent inflammation, like in chronic abscess in the lungs or any other location of chronic abscess, or chronic osteomyelitis, inflammation of the bones, is accompanied with such process that you studied before as amyloidosis. So that's why amyloidosis accompany some variants of chronic purulent inflammation. Next type of exudative inflammation is hemorrhagic inflammation, and it is characterized by the formation of the exudate, mainly represented by erythrocytes. Mechanism is based on the significant increase in microvascular permeability, followed by diapedesis of RBC. Immigration of leukocytes is low due to negative chemotaxis. Sometimes the content of RBC in exudate is so great that it resembles bleeding. For example, anthrax meningoencephalitis, when the meninge has reddish color and have specific name, red cap of cardinal. Etiology: these are severe infections, influenza, plague, anthrax, Also, some hemorrhagic fevers. Also, hemorrhagic inflammation sometimes can be seen together with other types of inflammation, especially in case of lack of vitamin C in patients also suffering from disorders of hematopoiesis. Usually localized in skin, mucosa of upper respiratory tract, GIT, lungs, lymph nodes, some parenchymal organs. Example of hemorrhagic inflammation, it is hemorrhagic pneumonia in influenza. Mucous membrane is swollen with dark red spots, areas of hemorrhage. Also, dark red spots can be found on the cut surface of the lung due to hemorrhagic exudate accumulation in the alveoli. Microscopically, we will see inflammatory fluid consisting from leukocytes, predominantly neutrophils, and some amount of macrophages, but the main cell type in exudate will be erythrocytes. Outcome depends on its cause, but favorable outcome possible very rare condition, because in majority of cases we will see unfavorable outcome, even death of the patient. Influenza bronchopneumonia, as I told before, multiple red dots in the bronchi, red areas of inflammation with erythrocytes in the tissue of the lung, and microscopically predominant cell type is erythrocyte. Putrid inflammation is caused by a group of Clostridial anaerobic infection pathogens from the Clostridium group, like Clostridium perfringens, Clostridium novii, Clostridium septicum. Usually these Clostridia are combined with aerobic bacteria such as Staphylococci or Streptococci. Most often, putrid inflammation is localized in wounds with extensive crush injuries. Also, putrid inflammation accompanies gas gangrene. Microscopically, we can see that wound edges are cyanotic, they are swollen, and subcutaneous fat is pale. Sometimes we can see necrotic muscles which has blackish color and infiltrated by gas bubbles. Due to such presence of gas bubbles, we can hear specific crepitation sound during palpation. Very unpleasant smell is present due to accumulation of such variant of gas. Microscopically, usually it starts like serous or serous hemorrhagic inflammation, which is very soon will be replaced with massive necrotic changes. Neutrophils can migrate into the inflammatory area but die quickly. When amount of neutrophils is increased, it can be estimated like favorable prognostic feature. Outcome is usually unfavorable because of massive destruction, reduced resistance of the organism, sometimes with massive antibiotic therapy, surgical procedures. When we remove the necrotized tissue, outcome can become favorable, but in very, very rare situations. Catarrhal inflammation can be caused by bacterial and viral infections, allergic reactions, effect of chemical and thermal factors, and toxins, for example, catarrhal uremic colitis and so on. Usually localized in mucous membranes and characterized by presence of exudate leaking from the mucosal surface. The main feature of catarrhal inflammation is that predominant substance in exudate is mucus. It can be a mixture of other types of exudate like serous, purulent, or hemorrhagic. Example is catarrhal tracheitis. Mucous membrane is swollen and full-blooded. Exudate drains from the mucous surface. It contains microscopically different type of leukocytes, desquamated epithelium, and predominant substance in the exudate is mucus, as was told before. Catarrhal inflammation can be acute and chronic. Acute often is associated with acute respiratory viral infections like influenza, respiratory syncytial virus, adenovirus, parainfluenza virus, and so on. We can see the changes in kinds of catarrh. Serous type of exudate can be replaced by mucus, mucus can be replaced by purulent, and sometimes purulent hemorrhagic in case of mild and severe forms of influenza. Chronic catarrhal inflammation occurs in infectious diseases like chronic catarrhal purulent bronchitis, or it can have non-infection origin like chronic catarrhal gastritis. Chronic inflammation in mucous membranes is often accompanied by violation of regeneration, that's why accompanied by atrophic changes of mucous membrane. Sometimes it can be opposite situation with hypertrophy of mucous membrane. In majority of cases, outcome is favorable with full, complete regeneration. Chronic catarrhal inflammation can lead to atrophic and hypertrophic changes in mucosa. At last, mixed inflammation usually is caused by combination of different infections. For example, viral infection with combination of bacteria. Or it can be one exudate which joins to another type of exudate. Can be like serous purulent, serous fibrinous, purulent hemorrhagic, and other types of mixed inflammation. Morphologically, it is combination of features for different types of inflammation. Outcome can be favorable, but in majority of cases it is unfavorable because few types of inflammation complicate one another. Now we are speaking about proliferative inflammation. In proliferative inflammation, how we can understand from the name, the proliferation phase is predominant. In etiology, we need to mention chronic viral infections, biological, physical, and chemical factors on the background of special reactivity of the organism. For example, we can see transition of acute inflammation into the chronic, in healing of ulcers, abscesses, and so on. This type of inflammation usually occurs when injurious bacterial or other agent is persistent in the organism due to imperfect exudative reaction, which is named incomplete phagocytosis. Usually it is due to special features of the causative agent itself. For example, Mycobacteria tuberculosis cannot be phagocytized and lysed by macrophages and persist in macrophages continuing its multiplication of Mycobacteria. Proliferative inflammation can be and pass like acute and chronic variant. Acute variant is observed in number of infections like typhoid fever, tularemia, brucellosis, and some allergic diseases like acute rheumatic fever, acute glomerulonephritis. Chronic proliferative inflammation occurs with periods of remissions and exacerbations. Outcome of proliferative inflammation usually sclerosis with the development of atrophy and shrinkage of organs, sometimes even with functional insufficiency, which is named cirrhosis. Proliferative inflammation can be classified and divided in 4 different types, which are interstitial proliferative inflammation, granulomatous proliferative inflammation, also inflammation around foreign bodies and parasites, and hyperplastic type of inflammation, or second name of such 4th type is inflammation with growth of polyps and condylomas. starting from interstitial inflammation, which occurs due to chronic viral infections, autoimmune disorders, or long-term chemical intoxication. Usually localized in stroma of parenchymal organs such as heart, liver, kidney, and lungs. On the photo we can see interstitial myocarditis. Macroscopically, organ usually not very damaged, and we can see only slight increase in sizes, irregularity of blood filling, and flabby consistency. Microscopically, inflamed organ is seen with damage to parenchymal cells, which are dystrophic and even necrotized, and accumulation of different inflammatory cells between parenchymal cells. In infiltrates, predominant cell type usually lymphocytes, with admixture of plasma cells and single macrophages. Neutrophils are very rare. Outcomes is development of connective tissue on the place of exudate. Sometimes it can lead to organ dysfunction, like diffuse cardiosclerosis after interstitial myocarditis, interstitial pulmonary fibrosis after some restrictive diseases of the lungs, and developing of particular organ insufficiency, heart failure, lung failure, or combination of heart and lung failure in case of these above mentioned diseases. Next type of proliferative inflammation is granulomatous inflammation. It is type of chronic inflammation in which specific small nodules and sometimes diffuse tissue infiltrates are formed. Predominant cell type in the cell infiltrates are cells of monocyte macrophage origin, like macrophages themselves, specific epithelioid cells, giant multinucleated cells. Granulomas can be classified due to few parameters. First parameter, etiology of granuloma. Granulomas can be infectious, non-infectious, and with unknown etiology. Examples of infectious granuloma are granulomas in tuberculosis, syphilis, rhinoscleroma, leprosy, and so on. Non-infectious granulomas usually formed around foreign bodies, such as particles of organic and inorganic dust. And granulomas with unknown origin can be seen in such diseases like sarcoidosis, Crohn's disease, and some other infectious and some other diseases in the organism. Due to pathogenesis, granulomas can be divided into immune and non-immune type. Immune granulomas often are represented by delayed type hypersensitivity reactions. These are infectious granulomas in predominant variants, sometimes can be seen around dust particles. Granulomas in infectious diseases reflect the relative resistance of the organism against the pathogen, which is named non-sterile immunity. Non-immune granulomas developing in the around foreign bodies but consisting from inorganic dust, for example suture material, or dust from the air in polluted cities. And non-immune granulomas passes without participation of specific organism resistance system from the pathogen. According to cellular composition, granulomas can be divided into macrophages granulomas, epithelioid cell granulomas, giant cell granulomas, and mixed granulomas. Let's see schematic image of different cell types in granuloma. In this photo we can see bacteria particles, which are Mycobacterium tuberculosis. They are phagocytized by macrophages. When macrophages phagocytize mycobacteria, they are damaged by this mycobacteria and can undergo apoptosis, transforming into apoptotic infected macrophage. Or this apoptotic macrophage can transform to epithelioid cell, or usual macrophage can transform to epithelioid macrophage. Epithelioid cells is predominant cell type in case of tuberculoma. Other cell types also participate in such type of inflammation. Epithelioid cells can fuse one with another, or macrophage can fuse one with another and form the giant cells. Multinucleated giant cells are present almost in all types of granulomas. Also, we can see another variant of transformation of macrophage into the apoptotic epithelioid macrophage, or we can see a mixture of different lymphocytes. Of course, if we are speaking about immune variant of granuloma, they can be T lymphocytes, B lymphocytes, natural killer cells, and so on. According to morphology, granulomas can be divided into non-specific and specific granulomas. Example of non-specific granuloma, it is alveococcus in the liver, parasite granuloma. In this disease, liver is enlarged, alveococcus occupies large part of the liver and represented by whitish in color dense node without clear boundaries, sometimes resembling tumor. Microscopically, we can see that alveococcal cyst is surrounded by chitin membrane and the connective tissue capsule. Both of them are eosinophilic, pinkish in color. Also, necrotic area present around capsule and granulomatous inflammation with excessive amount of giant cells of foreign bodies, lymphocytes, plasma cells and fibroblasts are found around the parasite. Outcome can be favorable if parasite will die and the capsule of it will be calcified, or can be unfavorable with spreading of parasite to other organs. There are four main types of specific granulomas, which are tuberculoma in tuberculosis, gumma in syphilis, leproma in leprosy, and scleroma in case of rhinoscleroma. We will start from tuberculoma. Tuberculoma localized usually in the lung in case of secondary tuberculosis. Macroscopically, we can see large area of caseous necrosis, which is whitish yellowish in color, loose in consistency and resemble cheese. Microscopically, zone of coagulative caseous necrosis, pinkish in color without nuclei. On the border there is connective tissue capsule. In connective tissue, multiple lymphocytes and plasma cells can be detected. Macrophages can be seen. Macrophages fuse one with another, forming epithelioid cells. Please don't make mistake with epithelial cells, because the name epithelioid means that cell is similar in appearance to epithelial cells, but it's not true epithelial because it originates from macrophage, not from epithelium. So elongated epithelioid cells, spindle-like fibroblasts, cells of connective tissue, and the most specific for tuberculoma and some other types of granulomas, giant multinucleated cells. They have specific name, Pirogov-Langhans cell. The feature of this cell is location of nuclei in the periphery of the cell, resembling horseshoe. There is another important variant of giant multinucleated cell, which is named giant multinucleated cells of foreign body. Giant multinucleated cell of foreign body has another variant of spreading of nuclei, and they are chaotically spread over the whole cell. In case of Pirogov-Langhans cells, we can see accumulation of nuclei only in the periphery of the cell. Outcome of tuberculoma can be favorable if granuloma become calcified or replaced by connective tissue. Unfavorable course leading to infiltrative type of tuberculosis or formation of cavity, which is named cavern, with subsequent severe scarring or with severe destructive damage to the lungs, with respiratory and pulmonary insufficiency, fatal erosive bleeding, amyloidosis in other organs due to chronic infection, and so on. Next variant of specific granuloma is named gumma, and it is present in the syphilis. There are two variants like gumma itself and gummatous infiltrate. Gumma can be localized in different organs and tissues, in bones, in skin, liver, brain, and parenchymal organs. Gummatous infiltrate usually located in the wall of large blood vessels, first of all in the wall of aorta. Gumma has its name because macroscopically it has also area of caseous necrosis, and this jelly-like mass resembles Arabic gum. That's why the name gumma. It can be surrounded by connective tissue capsule. Microscopically, we see pinkish eosinophilic masses of necrotized tissue caseous necrosis surrounded by lymphocytes plasma cells with admixture of macrophages and epithelioid cells, and also the same cell variant like in tuberculoma, which are multinucleated giant Pirogov-Langhans cell. There is very important distinctive feature for gumma which is different from tuberculoma. In gumma, in the wall of gumma, we can find blood vessels. Remember please, tuberculoma, in tuberculoma blood vessels are absent. These blood vessels are inflamed, so we can see endovasculitis in the wall of gumma. Gummatous infiltrate is similar to gumma but has no area of caseous necrosis, is more diffuse, and the gummatous infiltrate gives the intima of aorta appearance of shagreen skin, because there are a lot of shrunken areas in the intima of aorta. Can be complicated with rupture of wall of aorta with lethal bleeding. Next variant of specific granuloma is named leproma and can be seen in the leprosy, most often in the skin. There are two variants of leproma, tuberculoid variant and lepromatous variant. In tuberculoid variant of leproma, we can see high resistance of the host organism, and appearance of tuberculoid leproma is similar to tuberculoma. The lesions in the skin are diffuse, like papules and plaques, and the areas of inflammation in the skin later will become depigmented without melanin, forming the areas of so-named leukoderma. In tuberculoid variant of leprosy, changes in internal organs are usually absent. Microscopically, the tuberculoid form of leprosy, consisting from epithelioid cells granulomas, mycobacteria of leprosy can be detected very rare, and we can see the cell types which are similar to tuberculosis, like plasma cells, lymphocytes, macrophages, epithelioid cells. Sometimes we can see presence of giant Pirogov-Langhans cell, but very rare in case of tuberculoid variant of leprosy. Lepromatous form can be seen on the photos. Skin lesions have diffuse character and very severe. Appearance of skin, of face, similar to lion. That's why it has specific name lion face. Microscopically, we see specific for leprosy cells. Usually area of caseous necrosis is absent or is very small. The cellular types are lymphocytes, plasma cells, macrophages, epithelioid cells, and the most specific for leprosy cells, they have name Virchow cells. Virchow cells contain mycobacteria of leprosy. Using Zane-Nielsen staining, they can be detected and they are packaged like a pack of cigarettes. In case of effective treatment, outcome is favorable, even complete restoration. In unfavorable course, leprosy will lead to destruction of tissues with ulcers, with large area of necrosis, even leading to self-amputation, mutilation of parts of the body. Next variant of specific granuloma is scleroma, which is seen in rhinoscleroma. It is inflammatory disease of nasal cavity, nasopharynx, coans, larynx, trachea, soft and hard palate. Diffuse or nodular thickening of the skin and mucous membranes. Initially with soft but then very dense consistence. It is prone to ulceration. Microscopically, we can see granulation tissue with capillaries, and there is accumulation of macrophages, of epithelioid cells, lymphocytes and plasma cells. Amount of plasma cells is very high, so we can see sometimes Roussel bodies, which are eosinophilic degradation products of plasma cells. The most specific variant of cells are Mikulicz cells. These are clear macrophages which contain engulfed microorganisms, which are Klebsiella rhinoscleromatis microorganisms. Outcomes of such type of granuloma usually favorable. It is rapidly undergoes sclerosis and hyalinosis, but in very large sizes of scleroma it can cause asphyxia. Next variant of proliferative inflammation, it is hyperplastic inflammation or inflammation with formation of polyps and condylomas. In this table we can see difference between polyp and condyloma. Polyps are usually polyetiological. In condylomas the reason is human papillomavirus. Polyps are localized in mucous membranes, in stomach, colon, uterus and so on. Condylomas are located in the border of columnar and squamous epithelium, in external genital organs, skin of the perineum and perianal region. Macroscopically, polyps have fungiform or papillary exophytic outgrowths on the mucous membrane, located on the peduncle or the white basis. Condylomas are lesions on the skin with a lobed structure, resemble cauliflower or cock's comb, pinkish in color, also with peduncle or white basis, from few millimeters to dozens of centimeters in case of giant Buschke-Loewenstein condyloma. Microscopically, we can see growth of hyperplastic epithelium, and peduncle is formed by the connective tissue with blood vessels, in case of polyp. In condyloma, we will see microscopically villous proliferation of the stroma covered with squamous epithelium with acanthosis. Polyp outcome is inflammation and sometimes malignization. Condyloma the same, inflammation and, in unfavorable course, malignization of the condyloma. Next variant of proliferative inflammation is named inflammation around foreign bodies and parasites. Etiologically, we can see different animal parasites, even dead parasites, and some foreign bodies located in the parenchymal organs, in tissues, in superficial tissues that cannot be phagocytized or eliminated. That's why productive inflammation is formed around and to delimitate the damaging factor by connective tissue capsule. Example of inflammation around foreign bodies and parasites, it is inflammation around Echinococcus. Microscopically, we will see multiple inflammatory cells which surround the chitin capsule of parasite. So, first of all, chitin capsule of parasite, after that fibrous capsule formed by our organism, infiltrated by eosinophils, which are main cells in anti-parasite immunity, lymphocytes, macrophages, fibroblasts, giant cells of foreign bodies, epithelioid cells. It is typical cellular composition for such type of inflammation. Outcome of inflammation usually sclerosis and deformation of the wall of hollow organ where parasite is located. Character of inflammatory reaction around foreign bodies depends on its type of insoluble foreign body. If it is coal, asbestos or metals or talc, inflammatory infiltrate composes mostly from macrophages. In the end, we will see formation of connective tissue capsule. If the material is plastic sponge, suture material like catgut, beryllium, initially we will see acute inflammation with leukocytes, followed by quickly appearance of macrophages and giant cells of foreign bodies with the formation of connective tissue. Thank you for your attention.